you might want to draw this in exactly where the defect is. It's right between the two atries. Let's write that down for a minute. We'll talk about it. So obviously from this picture, the left side of the heart is the strongest, so it's pushing the blood through the defect between the atrias into the right atrium. So this blood is going to be unoxygenated, the blue, plus the oxygenated, that's the red, and we're going to get purple, meaning a mixed blood that's going to go into the right ventricles. Yes?
I don't really understand what you're supposed to do.
It's for your own benefit if you want to.
No, I want to draw it.
Okay, so just, if I were you and I had a heart, the normal size heart, I would circle in between my atrias and label it as ASD. And then I might also show that blood is being mixed down here in the right ventricle. So this is why we say that an ASD over here on the board is increased pulmonary blood flow, because we have oxygenated and unoxygenated blood mixing into the right ventricle and going up through the pulmonary artery to the lungs. So we're going to have increased pulmonary congestion or increased pulmonary blood flow. Kind of makes sense? Not really. So this is why these patients do not look blue, because they are still, this mixed blood is still going to go out to the lungs and get oxygenated and come back in the left atrium. So they're not blue and pale. Yes?
So does blood not go from the right atrium to the left atrium, only from the left atrium to the right?
Right, and why is that again? Remember that big powerhouse picture? Left side's the strongest, so it's going to push all that pressure this way. That's why it's coming through the defect this direction. And that's why that first slide we just saw a second ago is we have a left to right shunt. So the left side is the strongest. It's going to push everything through that defect. So like we just said, since these patients have that mixed blood but it's going out to the lungs to get oxygenated, they're not going to look pale, they're not going to look blue. They may even be asymptomatic. We may have to look underneath an echo to see that they have a hole between their atrias. However, they could have a murmur. They may present with some CHF because they have this increased pulmonary blood flow. They could have atrial dysrhythmias because the atrias with this defect are not going to pump correctly. So in order to treat this, we can place a surgical patch called a Dacron or a pericardial patch. And this is only if these patients have moderate to large defects. If it's a small ASD, they're going to see if the infant can grow out of it with time. They can also do open heart surgery if it's a large defect, and that will require the pulmonary bypass machine. And that's usually they're going to wait till the child reaches school age. They're going to try the patch as long as possible. And if they have to go in there, if it's a large defect, they'll go in and do open heart surgery. The next one we're going to talk about is a VSD, which again in the name gives it away. It's a defect between the ventricles. Same thing with the ASD. We're going to have a shunt that goes left to right because left side of the heart has all the pressure. It's the strongest. So let's take a picture, look at the picture of this and write it down. You can see the defect is right here between the ventricles. And again, the left side is the strongest, so it's pushing all that already oxygenated blood back into the right ventricle.
So
And it's mixing. Yes.
So the blood's flowing backwards, like it's already been in the left ventricle. It's like regurgitation almost, kind of.
Let's not use regurg.
Right.
But
No,
yes,
I know.
With that thought.
Okay.
Right. So it's going to be mixed over here and go out the pulmonary artery and go back to the lungs and get oxygenated. We do still have blood that's going up this way as well, out the aorta to the body. That's why these patients aren't looking blue because they're still getting oxygenated blood out to their body. So you can see how it would be easy for this right ventricle to have an increased cardiac demand because it's doing all the work right here. It's getting all the blood from the right atrium, and then it's got the left ventricle pushing all this blood into it too. So it's working overtime. So since the left side is the strongest, we call this a left to right shunt. Everybody have that picture down? So with these patients, you can imagine we're going to hear a loud murmur, and that's going to be over the lower area of the heart, or the left lower sternal border, because that's where the defect is in the ventricles. 20 to 60% of these can close spontaneously after birth, so they're not going to do anything. Again, if it's going to be a moderate to large defect, then they're going to have to go in there and do something. In this situation, they use pulmonary artery banding in infants. If you notice in that last picture, our pulmonary artery is getting all this blood, all this extra congestion, so they can do a band in there and kind of widen it out to compensate. Or they can do a complete repair, meaning they're going to close up those ventricles so there's no longer a hole between the ventricles. And obviously that would be the POC, which is the procedure of choice. This next one that we're going to talk about is a patent ductus arteriosus. And that is basically a hole or a defect between the aorta and the pulmonary artery. So in utero, usually this ductus will close, after the baby's born, usually this ductus closes. In utero, the baby uses it so that it can receive oxygen. A lot of times with the premature infants that you see in the NICU, everybody has open PDAs because they're premature and their body isn't ready to close that yet. However, they can live with PDAs if they're not big. If they're not moderate to large defects, you can live with it. So again, in utero, the infant uses this ductus to bypass the lungs because they're obviously not breathing. They're breathing amniotic fluid, and they can receive oxygen. So after the first few weeks of life, if this PDA is not closed, then they have to look at different measures that we're about to talk about. Just like the ASD and the VSD, this is going to be a left to right shunt. These babies can be born completely asymptomatic and you wouldn't know. However, most of the time you're going to hear a murmur, and that's going to give you a clue that something is going on. And it'll do a cardiac consult and look at an echo and discover that there's a PDA. As far as management goes, there's several different things that we can do. The first drug of choice would be what's called neoprofen, which sounds a lot like ibuprofen. So it's basically the same thing except for neonates. So they'll give neoprofen first, usually for about a week, and see if that will close the PDA because it is less harmful than the indomethacin that's written here, Indocin. However, if the neoprofen does not close it, they'll do around 3 rounds of Indocin, which is a very, very strong drug. It's given every 2 days, times 3. The problem with Indocin, though, is that these infants will have severely decreased urinary output, so the kidneys take a huge hit because of Indocin. They'll go back and do another echo. They'll listen for the murmur, see if anything's improved. If it still hasn't improved, they'll do what's called a PDA ligation, and that will be done at the bedside. It's a very, very small incision on the left side of the chest, and the doctor can go in and close up the PDA that way. And these patients are usually sedated. They'll be intubated for at least a week until they can get them off the ventilator. They'll have chest tubes. They're very sick.
Ms. Joe,
Yes.
the defect, is it between the pulmonary artery and the left atrium?
Pulmonary artery and aorta. We're going to take a look at it here. So if I had my little heart sheet of paper, I would draw that the defect is right here between the pulmonary artery and the aorta. An easy way to remember where this is, if you write out the letters P, D, A, then it's going to be a defect, the D, in between the pulmonary, P, and the aorta, A. It's kind of just this cheesy way that I kept it clear in my mind. So with this one, we don't have as visible of a shunting as with our ASD and our VSD, but you can still tell that there's a mixing of blood because the aorta is pushing the already oxygenated blood into this pulmonary So as we've written on the board, we've got increased pulmonary blood flow. So we've got these mixed blood going out to the lungs again. Alright, so when we talk about obstructive defects, these are the areas that we call stenosis, or a narrowing type of area constriction. The area before the obstruction is going to have increased pressure. The area after the obstruction is going to be decreased pressure. So I want you to think of like a straw, and you're holding a section of the straw with your hands pretty tight. You can still blow air through it. The area before that little stricture in the straw is going to have increased pressure because you're blowing really, really hard to get it through. The area after that little stricture in the straw is going to have a decreased pressure because it's already made its way through. The pressure behind is pushing it through. The first one we're going to talk about, we also talk about in lab today, is the coarctation of the aorta. And this is a narrowing or a stricture of the descending aorta. So this is going to restrict blood flow leaving the heart and going to the body systems. Just like we talked about, there's going to be an increased pressure proximal to the defect. And there's going to be a decreased pressure after. So in these kids, if it's going to be the descending aorta, the head and the upper extremities are going to be fine. You're going to have great pulses. However, the lower extremities, like if you're checking a fetal pulse, very weak. Very threatening. The main manifestation that we look at when we suspect that a baby's born with a coarc before we can get the echo up there to look at the heart is we do blood pressures. Usually there's going to be a blood pressure difference of at least 20 between the upper and lower extremities. So we'll put blood pressure cuffs on all 4 extremities and test the baby and see how much of a difference there is. If there's at least 20 or more, then we're going to suspect a coarc. And like we just talked about, the brachial and the radial pulses will be full, but the femoral will be weak because it's a defect or a constriction in the descending aorta. So there's several things that we can do to open up that area of the aorta that has the stricture. We can do a resection, or what's called anastomosis, that big word. And that's going to be using a graft, or you can use a portion of the left subclavian artery to do this. There's non-surgical repairs where you can go in and dilate, place the balloon, similar to what you think about a cardiac cath. The big key here is that we're going to use antibiotics prophylactically to prevent endocarditis. And we're going to talk about endocarditis. But basically endocarditis is a type of heart infection that can occur with the valves. And so when we do any kind of surgery such as this major open heart kind of surgery, we're going to want to give antibiotics before so we don't infection occur. Again, as far as evaluating these patients to see if what we've done has been helpful, we're going to look at their growth and development because, again, on that first slide with the assessment, we talked about how these patients are failure to thrive. So we want to see if they are gaining weight appropriately, if they're in the right growth parameters. We also want to look at the workload of the heart and see if we've helped minimize that. So this next picture, I'm not crazy about it because they did the best they can with it, but this is the coarc of the descending aorta. It does not have to be right here. It can be on, if we can rotate this heart around, it can be on the back side of the heart. Because if you remember, the descending aorta is going to go all the way down on the back side. And I talked earlier about a transesophageal echo and how we go down through the esophagus and look at the posterior side of the heart. So that would be great for this coarc to determine exactly where that narrowing is. So obviously it's not going to be before these main branches of the aorta shoot off, because if you remember, these are going to go to your head and your upper extremities. So, and those pulses are going to be fine. They may even be bounding. So that's why the stricture is going to be after, somewhere along the back. Again, they did the best they can, but it's not necessarily right there. It can be anywhere along the back of these.